Thank you, Megan, and my pleasure to welcome everyone to the KT Canada seminar today. The title of today's talk is Patient-Oriented Knowledge Translation, Implementing Shared Decision-Making in Practice. Now, before I introduce the speaker, Dr. Sarah Munro, I will introduce myself first. I am Linda Lee. I am a professor at the Department of Physical Therapy at University of British Columbia, and I have the pleasure to moderate today's session. Just before we start, I'd like to remind everyone that your speaker, your phone is on mute when you enter, so that there wouldn't be any noise to interrupt during the presentation. If you have any questions for the speaker, I would invite you to type it in the chat box on WebEx and share it with everyone, and we'll take questions after the first 40 minutes of the presentation. So it is my pleasure to introduce Dr. Sarah Munro. Sarah is a qualitative health services researcher whose focus is in knowledge translation and implementation science. She just recently completed her PhD in interdisciplinary studies at UBC, where her research focused on implementation of shared decision-making interventions for patients and their care teams. Sarah is currently a scientist with the Center for Health Evaluation and Outcomes Science and holds a joint postdoctoral fellowship with UBC Department of Family Practice and the Dartmouth Institute for Health Policy and Clinical Practice in the U.S. So please join me in welcoming Sarah, and I will pass the speaker to her. Sarah, whenever you're ready.
Just doing a sound check. Can you hear me clearly?
Yep, you sound good now.
Excellent. I was, still muted before. Thank you, Linda. It's a pleasure to be able to present some of my research today. As Linda mentioned, I hold a joint postdoctoral fellowship. So even though I am conducting research in the eastern U.S., I still have a community of practice here in Vancouver, from where I'm presenting today. And it's a continuation of my PhD research. My research seeks to understand people's behaviors and attitudes when it comes to implementing practice change. And I use qualitative methods to understand in depth what quantitative data may not be able to express, and to help bridge evidence to practice gaps across the healthcare system. So it's great today to speak to an audience who is already immersed in knowledge translation. So I can probably skip ahead a lot of the background material that I usually would for an audience that's not familiar with KT. This research is being supported by competitive grants, as well as a variety of consulting contracts and relationships with health authorities and Dartmouth College. And my talk is about patient-oriented knowledge translation today, implementing shared decision-making in practice. So what do we mean by patient-oriented KT and by shared decision-making? In Canada, shared decision-making is closely linked to the concept of knowledge translation in healthcare. And this is possibly due to how funding agencies have explicitly supported KT in healthcare decision-making. What I'm going to speak about is a tool that supports shared decision-making called patient decision aids. And these are seen as a promising KT strategy for producing and communicating evidence to patients. Shared decision-making is a model of information exchange, and patient decision aids are meant to support those shared decision-making interactions. Decision aids can be used before a clinical encounter. They can be video, paper-based, or a website used by the patient alone. They can be used during the patient and provider interaction. And in those cases, it could look like decision coaching with support from index cards or one-page exercises. And there are also provider-focused interventions that seek to promote the development of shared decision-making skills and behaviors. The core components of a patient decision aid are slightly different from if you're providing the patient with information alone. So one of the key attributes of a decision aid that makes it distinct is it seeks to help the patient clarify the attributes of the decision that matter most to them. So what are their values and preferences? And how can the options and the benefits and harms of those options, what's most important to a given patient in their life? In a shared decision-making encounter, at least 2 participants are involved, but usually there's more than just the patient and practitioner. Family, other members of the healthcare team may be involved. And there are 4 core steps. So first, there's a discussion of the clinical evidence of options and those benefits and harms of the options. The patient then goes through some steps to think about his or her values and about the options, attributes, and outcomes. And then together, the team takes steps to build consensus about a preferred choice or treatment plan. And together, they have a sense of shared responsibility for the treatment plan. Different from informed choice decision-making, which is really more common now in Canada, where the provider gives evidence to the patient and the patient makes the choice alone. It's also different from an authoritative or more paternalistic approach, where the patient expresses their preferences to the provider and then the provider makes the choice. In shared decision-making, there is this meeting of 2 experts. So the expertise of the provider giving clinical evidence to the patient and the expertise and lived experience of the patient who has to communicate their preferences to the provider. In spite of these benefits, there's benefits to patient decision aids that have been reported in numerous randomized controlled trials. This here is the most recent Cochrane review published last year, led by Don Stacey and team. And we know from this large body of evidence that decision aids have a positive effect on patient knowledge, accuracy of risk perceptions, and there's an increased likelihood that they'll choose the health option that matches their informed values. They also, patient decision aids also help to decrease the decisional conflict, or what we talk about as patients' readiness and confidence to make a choice. They also increase patient satisfaction, and in some cases, we've seen that decision aids help to reduce the number of people who choose surgery in comparison to non-invasive options. So there's potential for improvements in health outcomes. And yet, in spite of these benefits, there's limited evidence to suggest that decision aids are effective to increase the use of shared decision-making by healthcare professionals. So this is a recent systematic review. Actually, the citation there should be updated to say 2018 by France Legaré and team. She's a Canada Research Chair in Shared Decision-Making and Knowledge Translation. And what they found from their review is that in spite of these positive effects for patient experience, decision aids aren't necessarily, we don't have the evidence right now to say that they support the implementation of shared decision-making. So why is this? Why, in spite of their positive effect on patient outcomes, is it so hard to adopt shared decision-making in routine practice? And this is where the knowledge translation and implementation science literature can be helpful. We can start by looking back to, this is one of the formative reviews on implementation of practice change for clinicians. So Cabana's review of clinical practice guidelines. We can understand what some potential barriers and facilitators to implementing a tool like a decision aid might be. France Legaré's team actually conducted a review that was based on the barriers and facilitators from Cabana's original review. And more recently, Natalie Joseph-Williams, my colleague Glenn Elwyn, and Adrian Edwards in the UK did a review of patient-reported barriers and facilitators. What we know is from these various reviews that there's a range of factors that could mediate the uptake of shared decision-making. Primarily knowledge and attitude. So often healthcare professionals say, well, we do this already. We do engage in shared decision-making. So there's a misperception of what's happening in practice and what needs to be adopted. Often there's limited knowledge of healthcare professionals of the components of shared decision-making. And what I'm interested in is what we know about some environmental barriers. So what's happening at the organizational and health system level that could mediate the implementation of a decision aid. So, for instance, organizational constraints, not having the resources to take a paper-based tool and put it into routine workflow. There could be financial disincentives. For instance, if one of the healthcare options that's being talked about in the decision aid is if a care provider receives more remuneration or a fee for service that's greater for that option than the other, there may be some bias involved in doing a shared decision-making discussion. Of course, there's power imbalances in patient-provider relationships, and that affects the discussion, and workflow concerns that may affect not just the healthcare provider, but other staff in a hospital or clinic setting. So how do we design and implement and evaluate shared decision-making interventions that address these potential barriers? Well, we have some guidance from patient decision aid experts. There was a wonderful series published in BMC Medical Informatics and Decision Making in 2013 by the International Patient Decision Aid Standards Collaboration. And this is one of those papers where experts go through a stepwise process on how to create a decision aid that has a greater likelihood of being useful and usable for end users. And not surprisingly, this guidance follows many of the steps that we would expect for the creation of any KT strategy. So we begin by defining the scope and purpose of the decision aid and target audience. We assemble a steering group, including end users like clinicians and patients, and then go through a process of assessing decisional needs. So what do patients need? What do clinicians perceive that patients need in supporting making a decision about a particular clinical topic? We go through the design of the format of the decision aid and planning for implementation. How will this be distributed in routine practice? And then there's this step of reviewing and synthesizing evidence, which I'm going to talk about a little bit more throughout the presentation. And these steps are then followed by prototype development, pilot testing for usability, and then feasibility testing in a real-world setting. But there's still some room for improvement in this stepwise process for development. As Angela Coulter and her colleagues write in this paper, we still don't know what the optimal methods are for determining end users' decisional needs in different contexts, and what are the different characteristics of potential methods. And what are the barriers and facilitators to implementing decision aids in different contexts? These are really big questions. And we also don't really know how those barriers and facilitators can be addressed, not just post-implementation, but at the pre-implementation development stage. So at the beginning of my PhD, I was really interested in these sorts of questions and recognized that there was a bit of overlap with the knowledge translation literature. And in Canada, I'm going to assume that we're all familiar with the knowledge to action cycle. As someone who develops patient decision aids, I see gaps between tool development and tool adoption in the literature and in my own research. And I see that there's room for improvement in these. There's room for improvement in how we develop decision aids by paying attention to two particular phases in the knowledge to action cycle. Adapting knowledge to local context, and assessing barriers to knowledge use. And I'm going to argue that by understanding the local context in which shared decision-making tools and decision aids are used, we might get closer to creating tools that aren't just effective, but are also adopted. So in my research, I'm also going to talk about the integrated knowledge translation approach that underpinned my process. Again, I assume that we're all familiar with the concept of IKT, in which knowledge users are members of the research team and they participate throughout the research process. And by involving knowledge users as equal partners, our assumption is that this will lead to research that's more relevant and more likely to be used by the knowledge users. In the context of my study I'm going to talk about today, the knowledge users were frontline users and users of potential decision aid. So that included patients and healthcare professionals, but it also included people at the organizational and system level. And this is, harping back to what I said before around potential environmental and organizational barriers to implementation. So we included on our team administrators, managers, and health system decision makers. So my goals today, after now going through the evidence on the evidence to practice gap for implementing shared decision making, I'm going to now describe a case example involving the health system factors that influence FDM, shared decision making, for choice of next birth after cesarean section. And then I'm going to talk about our experience of doing IKT and some practical implications for developing FDM, shared decision making interventions. So My Next Birth is the name of the study where we were exploring how to implement a shared decision-making intervention for patients who had experienced a previous C-section and were considering their options for a next delivery, either a planned vaginal birth after cesarean or a repeat elective cesarean section. In British Columbia, where we conducted the study, the uptake of these options isn't a reflection of what the evidence suggests should be taking place. So of women in British Columbia who are eligible to have an attempted vaginal birth after cesarean section, only 1/3 take up that option, and 2/3 plan an elective repeat cesarean section. Of those who attempt a VBAC, 7 out of 10 will have that VBAC as planned, and the remaining 3 out of 10 will have an unplanned cesarean section. But we know in Canada that of women who have had a previous cesarean section, over 80% are actually good, healthy candidates for having a planned VBAC. And this disparity between the recommendation and who's eligible and who actually takes up this option, it can't be explained by the risk status of patients, any diagnoses that come up during pregnancy. It could be explained by hospital characteristics and some sociodemographic characteristics, but we, at the outset of this research, had some idea that perhaps it was related to decision-making, that the currently low rates of uptake of planned VBAC were because decision-making was, there was some room for improvement in how these decisions were being made. In Canada, clinical practice guidelines have had little impact, and one reason why we want to have low C-section rates is because it's major surgery. There's an increased chance of infection, of hemorrhage, of transfusion. It can lead to problems for future births. And from a patient-centered perspective, while some women do prefer cesarean section, we also know from survey-based data that the vast majority would prefer to have a vaginal birth. So there's an argument to decrease C-section rates to promote patient-centered care. There's evidence that VBAC rates vary by hospital, and patient decision aids have been largely not effective at changing rates of cesarean section, even though they do increase patient preferences for planned mode of delivery. Those decisions are generally not implemented. So we do have some examples of patient decision aids that could be implemented more effectively. So for our study, the overarching research question that we began with was, what are the factors that influence implementation of shared decision-making in the context of mode of delivery? And there have been 2 key phases to this study. The first, which was the subject of my PhD, was a mixed methods needs assessment to understand the context of implementation and the decisional needs of patients and healthcare professionals. So I conducted interviews followed by 2 regional surveys, and throughout engaged in IKT activities. And I'm going to speak at the end of the presentation really briefly about our design and testing of a shared decision-making intervention that we have developed based on the learnings from phase 1. So the first method we used for understanding context and decisional needs was in-depth interviews. The objective of this phase was to identify barriers and facilitators to shared decision-making, and we explored the attitudes and experiences of women healthcare providers and health service decision-makers. In British Columbia, we chose a purposeful sample of 5 communities that were quite diverse and in rural and urban settings. And our design was informed by constructivist grounded theory. And I chose that approach, which is very interpretive and exploratory, because we had little knowledge of what we were going to find around decisional needs, and especially environment and context of implementing a patient decision aid in maternity care. These were in-depth semi-structured interviews, and my data collection and analysis was ongoing and concurrent. So as we conducted interviews, I did analysis of the interviews, integrated my findings with my IKT activities. So as we were getting our preliminary learnings, we were sharing with the rest of the multidisciplinary team and getting feedback on interesting findings. In total, 57 participants were engaged in interviews, including women, care providers, and decision makers at the hospital level, in the 2 regions, and at a provincial level. And the 5 sites were those in northern BC, so Terrace, Prince George, and Fort St. John, and down south in the Fraser Health Authority here in BC, in New Westminster and South Surrey. So some of the key findings that we learned from women were that in their decision-making process, women seek to be in control of their process in the midst of the uncertainty of what their next birth might look like. So this included being an active participant in their healthcare decision-making process, wanting to have some power to influence or direct behavior or events during their pregnancy and in their labor and delivery. This also meant having some degree of control over their body, their childbirth experience, and very importantly, their mental well-being. And this was often in response to a feeling of not having any control over their first cesarean birth experience. Being in control resulted for participants in a sense of realistic expectations for their next birth and a sense of safety and satisfaction. So here is an example from one of our participants who talked about this notion of how important it was to be in control. And she talks about the timing of the decision. So right here, she's speaking about her decision-making process in between pregnancies. She said, "I need to plan this birth so that it helps me keep this anxiety in control." So that was a deciding factor for her choice of mode of delivery. Going into having a VBAC would be giving up that control that I was working for to keep the depression and anxiety away. So that added to it too. I'm going to plan this C-section, and then I'm going to plan my doctors around it. Here's another participant speaking from her urban community. She was under midwifery care through most of her pregnancies, and she was currently pregnant in the context of this interview, and this was her 3rd delivery. I want to point out that in her hospital setting, she had been told that the protocol was no chance for a vaginal birth after you've had 2 cesarean sections. That's actually not consistent with best practice guidelines. And she was also told that suspected macrosomia, so this is having a baby that appears to be larger than is appropriate for its age in utero, that's actually not a contraindication to having a trial of labor after cesarean section, but was told that having a suspected large baby actually is a reason for a C-section. So that's just a bit of context, and let's go into her experience of decision-making. She says, "I had gestational diabetes in my 2nd pregnancy, and they were concerned about the size of the baby. And then when I got the scan done, everything showed it was going to be a super big baby. I panicked and said I don't want to go through that experience I'd gone through before, so I opted to do another C-section. I went to see another OB. It turned out to be the same one who had done my 1st one, and the decision was made to do a 2nd one. So I didn't realize this, but it seems to be the case that when you've had 2, when you have your 3rd, they don't really give you the option between a VBAC and a C-section. So I'm scheduled to have one right now. Choosing my 2nd cesarean was not an easy decision. It wasn't like, this is just what I'm going to do. We did talk a lot about it. It was deciding that I was not ever going to have the chance to have that vaginal birth. I always thought maybe I'd be the person who's lucky enough, the way I look at it, to have that beautiful moment where your child comes out and you see it and it lays on you and it's right there. I didn't get that. So deciding that I was willing to let go of that dream was challenging." So what we see here from these 2 participants' experiences of decision-making is that they felt they had to make trade-offs between the attributes of the decision in order to have a healthy baby. And it wasn't necessarily based on best evidence and clinical recommendations that you might have in a different hospital. Primarily, they felt that in order to maximize the health and safety for them as a mom and for their baby, they had to give up the experience of a vaginal birth. And as you saw for that second participant, even though she chose to have repeat C-sections, she still had that desire for a vaginal birth. So it means that she maybe wasn't making a decision that was consistent with all of her values. What we also see from this data is the timing of the decision. So this is a graphic that we have developed to show what the decision-making process looks like and the timing of the different choices for women during their pregnancy. And we see here that women formed a preference for their mode of delivery earlier than reported in previous literature. And this means that the timing of previous decision aid interventions was probably too late because those are primarily administered in the next birth. So going through these different events in the decision-making pathway, we see here that at the time of cesarean, participants recognized that there was a decision to be made for their future birth. They had an option for a mode of delivery for their next pregnancy. And during their interpregnancy interval, they began to form a preference. First, reflecting on their birth and clarifying what mattered most to them, becoming informed, considering what was feasible, and then in some cases, deliberating with healthcare providers. For that becoming informed stage, we also learned that women primarily went to friends, peers, and family for information in between pregnancies. And often that information was sought out to provide comfort and a sense of community, but it also contained information about their future options. It was often unbalanced and inaccurate. We also learned that women sought to avoid environments that would re-traumatize them. So one participant even decided to avoid her local hospital entirely for her next delivery. She moved to another community that was 2 days' drive away where she could have a home birth with an unregistered midwife in order to avoid an environment that she felt wouldn't give her the option of her preferred mode of birth. Now I'm going to talk about healthcare providers' experiences and attitudes toward the decision for mode of delivery. Healthcare providers felt that their role in the decision-making process was to support women to make the choice. And this meant engaging in informed decision-making, being an information provider. So if you remember that graphic I showed you at the beginning, the table, in terms of the direction of information flow, primarily they felt that the information should be given to the woman and she alone should make the choice. They did feel that it was important to listen to the woman's voice, but often there wasn't a conversation that took place where the woman's voice came first. It would be the care provider providing evidence, and then the woman would talk about what that evidence meant to her, which created a bit of an imbalance in the information exchanged. They also spoke a lot about health system resources. And decision makers in particular that we interviewed highlighted the influence of resources and different policies on the decision-making process. So one key attribute, for example, that came through in interviews was health decision makers and healthcare providers' concerns about having the resources needed to support the option of a planned VBAC. In BC, all hospitals that offer a vaginal birth after cesarean, they have to have emergency C-section available within 30 minutes or less. And the reason is because there's a 1 in 200 chance of a uterine rupture, and that's where the scar from the cesarean section opens during labor. And if that uncommon event happens, then delivering the baby by C-section within 30 minutes reduces the chance of harm to the newborn. But we learned that providers in the larger hospitals where interviews were conducted, it was sometimes difficult for them to meet that threshold. And here's an example from an urban practitioner who says, I can't guarantee the patient I have in front of me that all things being equal, I'll be able to do that C-section in the time prescribed. And it comes down then, the patient says, well, what do you mean you don't have the resources to? Well, that's the way it is. And in the 8 sites that we function, we cannot provide the expected standard of care. So you have a choice to make that given the low risk of uterine rupture, whether or not you wish to continue with that choice for a vaginal birth, for instance. So that's probably one of the biggest impediments, because from the physician point of view, there's a fear of a damaged baby. And in the context of this fear, practitioners try to make it work and offer VBAC in the midst of limited access to services. In rural communities where they have fewer resources, they actually came up with some creative strategies for making sure women had both options available, including communicating with off-site staff during a trial of labor. In urban settings, they primarily communicated risks through informed consent and consent forms. So there was an emphasis on the risks of mode of delivery and the risks of vaginal birth, creating a lot of imbalance in the information exchange and imbalance in presenting the options available. So what we learned from this in-depth interview study is that women formed a preference for their mode of birth in between pregnancies when they're not engaged with the healthcare system, which creates a bit of an implementation conundrum for us. When do we time an intervention to support shared decision-making if women are making these choices before they're even seeing a healthcare professional? We also see that contextual factors work together synergistically to influence women's preferences, that different forms of knowledge, not just clinical evidence, inform their choices. So I didn't really mention this. Another interesting finding was that healthcare providers felt that they did have enough time to engage in shared decision-making, that they didn't feel any time pressure, that there was a lot of opportunity over the course of pregnancy to go through a rich shared decision-making process. And that's different from what we find for other clinical decisions, where healthcare professionals feel that maybe they only have 10 to 15 minutes to go through a deliberation with a patient about their options. What was also really wonderful was to see positive attitudes towards shared decision-making. So all healthcare professionals interviewed were very willing to engage in the constructs of shared decision-making and felt that it was very important in maternity care, especially where there is that sense, and this is maybe unique to maternity care in comparison to some other clinical areas, but there was this sense that you need to have some sense of shared responsibility over a decision, and that women should be informed and involved in their choices. We saw the influence of environment on decision-making patterns. And what was an interesting contribution of this particular study is that even though we've seen these represented in other previous literature reviews and studies, these factors and the relationships between them and how they influence each other had not been previously reported. So as I mentioned, these factors had come up in previous reviews on implementation of shared decision-making, but when examined in isolation, these discrete barriers and facilitators have provided a bit of a narrow perspective on the factors that support or impede evidence-based practice for birth after cesarean. And if we instead look at a complex systems approach and the system as a whole, we can see the synergistic relationships between these different barriers and facilitators. So going back to what that physician participant had spoken about, they focused on the risk of uterine rupture. That behavior was influenced by medical legal concerns and fear of a damaged baby, and those concerns stem from having a lack of emergency C-section resources, which in turn were influenced by having budget constraints and a policy context where maternity care and cesarean section had been a rather low policy priority. So the next phase of our data collection was to conduct a series of surveys to see if our findings were transferable to some other settings and to understand what shared decision-making interventions would be acceptable to healthcare providers in BC. We conducted these surveys in fall of 2016 and winter 2018. We included obstetricians, midwives, and family physicians in the first survey, and then added nurses to our sample in the second survey. And for both of these, the funder was not peer-reviewed funding. Instead, this was after, I'm going to talk about our IKT activities, but one of the interesting impacts of the process I'll point out is that the study partners were deeply involved in conducting these surveys because they wanted to get data that could help them with an implementation of shared decision-making strategy later on. The questionnaire went through healthcare provider demographics, their practice patterns. We questioned them about their perceptions of access to cesarean section, their experience with adverse outcomes and with shared decision-making. We looked at their current patient-provider communication strategies and also administered the subscale of the control preferences scale to see if we could see the same pattern happening, that healthcare providers felt that they should be involved and share the responsibility for maternity care decisions with their patients. So there were 308 complete responses to the surveys, and our findings were consistent with what we found in the interviews. The participants would support implementing shared decision-making. They thought it was consistent with usual practice, and yet barriers to implementation were diverse. Patient and care provider decision-making patterns that meant that they weren't engaging in the elements of shared decision-making. We saw that that was a common barrier. We found that actually a lot of sites felt that they had good hospital access to planned VBAC, so that perception that we saw in some of our larger sites in the interviews didn't hold for this survey. Again, time pressures were not a factor in most settings, but because a lot of the sites felt that they had access to planned feedback, medical legal concerns weren't a factor. So our study sought to adapt knowledge about shared decision-making and implementation of decision aids to local contexts. And we had another layer of research methods that I'm going to speak to briefly now, which was to engage in IKT activities throughout the research process to ensure that our findings would be more useful and usable to the knowledge users who would hopefully be adopting interventions to support shared decision-making. I'm going to talk now about the third method of our study, which was our IKT. In our activities, we began by co-designing our research questions. Our partners from health authorities and healthcare professionals were involved at each phase of recruitment and data collection. And we also engaged in a lot of meetings and face-to-face interaction to develop trusting relationships. And the purpose of doing the IKT was really twofold. Well, first, I wanted to maximize the chance of impact. I wanted to do applied research, and the healthcare decision makers, they really wanted to engage in systems change and promote patient-centered care. But secondly, this is also how I was trained. I come from a background of doing community-based research in rural communities. So when I moved into KT science in urban environments, it was just an imperative that I use the same principles in my research. I'll give you an example of some of the activities that we engaged in. We started out in one region having monthly meetings to understand the needs of healthcare decision makers. And at the end of our data collection and analysis, this team in Fraser Health and I, we co-produced a policy brief. And that policy brief basically took my dissertation and distilled it into 4 pages with an executive summary. And we shared those findings with one of the provincial organizations that's in charge of maternity services and quality, that's Perinatal Services BC. We also shared it with the BC Ministry of Health Division that is responsible for women and child health. I gave presentations where I brought this policy brief. I gave in the study communities and at different health authorities. In response, there was this wonderful kind of dialogue and knowledge exchange that then took place. The ministry asked me to create 2 evidence reviews that kind of did a deep dive into some of the recommendations from the policy brief. And the impacts of these IKT activities were unexpected and rather lovely. So we created a working group as a result of doing the research together. And this working group wasn't led by me, it was then led by the Ministry of Health. So the policy recommendations that came out of our working group were ratified by perinatal services, and they actually engaged in a bit of policy change. They developed a new quality indicator for attempting VBAC as a way to create some health system support and motivation for hospital sites to create the supportive context to engage in shared decision-making about the options for mode of delivery. This is the indicator here. It's also a wonderful resource for patients. You can see what your hospital's VBAC attempted rate is and compare it with other communities. And it's also helpful for our decision aid development process because this data can be integrated into the decision aid to make sure that what individuals see is tailored to their local context. And so the other IKT work that we engaged in was talking about this decision-making pathway and figuring out what sort of tools or interventions should we develop based on the big gaps that we identified. So these gaps in patient-oriented KT were really after that first cesarean section, when women start to form a preference, during the postpartum period, when preferences are clarified in the interpregnancy interval, and then during the next birth, when they enter the healthcare system again. So our IKT activities evolved into not doing primary research, but doing some tool development. This working group that was developed by the Ministry of Health supported some user-centered design activities. We did this in partnership not just with health system decision makers, but we had frontline healthcare professionals engage in cognitive interviews to understand what worked for our prototypes. We have 5 patient partners who have been involved throughout this process as well. And we identified 2 key interventions. The first is a debriefing exercise to help care providers talk with women after their primary cesarean section to make sure that they're getting an understanding of what happened in their first birth and how that C-section might influence their future choices. And the second is a website. It's an online interactive decision aid, and it provides tailored information on the options and their benefits and harms, and it has a preference report that the patient and provider can talk through. It's called What Matters Most to Me, and it's meant to be used as a discussion tool during a clinic visit to help guide a shared decision-making interaction. This is the screenshot of the landing page for the website. It includes 5 sections that a patient will navigate through. The first one, it helps the woman understand her options for mode of delivery. The second part provides information about what's available in BC and asks questions about the user's personal health history. Then the user goes through some information about benefits and harms of the options and a values clarification exercise so the woman can actually talk about her preferences and what matters most to her. She then reviews the decision and then produces the What Matters Most to Me summary page. Currently, where our pilot testing with providers and patients is complete, we're going to be doing feasibility testing after our next IKT activity, which is to create the implementation plan for this website, come up with some ideas for our debriefing exercise after the first C-section, and we're also going to choose some outcomes to collect. And this is largely out of my hands now, which is fantastic, and it speaks to the IKT relationships and the sustainability of this work. So the Ministry of Health and Perinatal Services are in charge of this it's not research now, it's really a program, and I'm providing research support. So we're going to proceed in this project. The next steps will be doing more online user testing of the decision aid, debriefing exercise like I mentioned, and one of the things that we're struggling with right now around measuring the effect and the implementation of this website is to see really how do we capture outcomes on the effect of this website strategy on actual rates of attempted feedback and on the experience of shared decision making. And one of the reasons why this is difficult is because we're looking at collecting data over a long period. We imagine that the website may be first visited by women in between pregnancies and that they could revisit it in their next pregnancy. And that interval of time can be 2 or 3 years. So creating a cohort and capturing data is longitudinal, and it can be quite complex, especially if you're dealing with patient-reported data. But we can learn from some potential study designs from international settings. And this can help us by using some appropriate KT methods and frameworks that can help us in a process evaluation way to identify and mitigate barriers and scale-up facilitators. So this means that in addition to collecting outcomes related to the website, we can collect some outcomes around how it gets used, how people are integrating into their routine workflow. Some great examples of work that in this area is the Right For Me trial that I've been a part of at Dartmouth College. And that's looking at implementation of a contraception decision aid. And there's the MAGIC program in the UK, and I'd encourage you, if you're interested in this area, to read the recent work by Natalie Joseph Williams and team that was published in BMJ last year. So in conclusion, using mixed methods can yield a more nuanced understanding of the context, barriers, and facilitators to implementing shared decision-making in comparison to using a single method alone. During the development of an SDM intervention, IKT activities can help to mitigate barriers and scale up facilitators. However, as I'm sure this audience knows, IKT activities are time and resource intensive. Future research that our team is looking at, and I'm interested to know who else might be working in this area, is we're hoping to understand the characteristics of IKT activities that are most effective at creating a supportive context for implementing SDM, and other methods in addition to interviews and surveys that could explore patients' decisional needs. And I want to acknowledge the many collaborators and funders who have been involved in supporting this research, and hope that we can now have a bit of a conversation. Thank you for the opportunity to present this work.
Thank you, Sarah, for the excellent presentation. I certainly learn a lot every time when I hear you talk about this particular topic, so that's wonderful. To everyone in the audience, if you have any questions for Sarah, I'll invite you to type it in the chat box on WebEx, and we will present that to Sarah to answer your question. But while everyone is thinking about the questions to ask you, Sarah, I'm particularly interested in your IKT activities that you have talked about, and I wonder if you can perhaps speak a little bit more about what the IKT activities that you've conducted have added to your own research process.
Sure. So our IKT activities, I'd say one of the best outcomes, impacts of them, what they really added was to make this particular topic a priority for not just the research users involved, but the people that they worked with. So some examples are that in working with the Fraser Health region, they learned more about shared decision-making and how to implement it, how they might implement it. One hospital group decided to hold a CME day on how to do shared decision-making for mode of delivery. Another group took the tools that we used, our policy brief and evidence reviews, and they showed their managers, this is what we're working on, and it was a way to show that some action and movement was happening around mode of delivery. It also changed how I saw the research, and for me as a researcher, doing the IKT activities really helped me to understand and make sense of context, so that when I was engaging with the data and making a plan for the decision aid, my approach was really grounded in what was happening in different hospital regions, and I wouldn't have had that if I'd not engaged with the research users.
That is great. Thank you, Sarah. Now, I believe there are some questions that Megan is to you. Megan, would you like to?
Hello. Yep, I can take over from here. So we've gotten a question from Ottawa. So they were asking, is there a target set for the, I don't know how to say this exactly, but VBAC attempts in the PSBC indicator?
Yes, so the Ministry of Health has set a target that is unpublished of 50% by, I believe it's 2022. The strategies to achieve that are diverse, and the decision aid and shared decision making are just one component of it. But that's their kind of blue sky ideal benchmark.
Okay, thank you. Let's see here. I have a few more questions. So the next question for you, what would have been different if you had not engaged research users throughout?
Well, first and foremost, if I hadn't engaged with the research users, I wouldn't have had as many funding opportunities for the research. Going through the competitive peer-reviewed process to achieve funding for research like this, it often doesn't match up with the timeline that policymakers want. So they were able to put up research funds and salary support for me to engage in this research. That was a huge benefit. I also probably would have made the decision aid at the beginning of the research process and spent the last 2 years testing it. And instead, what we saw was by doing the IKT activities, there were health system changes. So one hospital took our research data and hired more staff for their OR, which created a better context to engage in shared decision making, because that hospital now has equal access to options for mode of delivery. And our decision aid potentially has a chance now of being useful and usable in practice.
Awesome, thank you so much. We have a question now from Queens. They said, thank you for a very engaging presentation. With your first study, you used a constructivist grounded theory. Can you speak more about the theory that you ultimately developed, and if you plan on testing that theory?
Oh, yeah. So the two theories that we developed are really the overarching themes that I spoke to: seeking control in the midst of uncertainty and making it work in the context of limited resources. In terms of testing that theory, we did seek to test it through the surveys, and really it's that making it work in the context of limited resources. What I would like to do is to take those theories and test them ethnographically in an implementation study. So I'd really like to do some observation in settings where the patient decision aid and different shared decision-making strategies are eventually implemented, and to see if our theory and what we learned from the in-depth interview study pre-implementation, and if that holds post-implementation and how it might change.
Thank you. We have another question. This is from France Legare's team. They asked, in your study, did you compare women with different ethnicities?
Yes. And I have some data from another study that we did that tested a patient information pamphlet on the choice of mode of delivery. And the different ethnicities involved in those two studies were primarily women who identified as Asian or Indigenous. And we didn't, and when I say Asian, I mean from China and from South Asia, India. And what we observed there in terms of differences with Caucasian participants was two key things. First, that for the Asian and South Asian participants, they spoke often about cultural expectations based on what family and friends had experienced in healthcare settings outside of Canada, that cesarean section was more normalized in those settings, and choosing to plan a VBAC was seen by friends and family as more risky than planning a repeat C-section. So there's a lot of pressure that they spoke about from friends and family. The other piece from Indigenous participants was talking about ongoing relationships with their rural hospitals. So what it means to be an Indigenous woman engaging with a healthcare team and different experiences of receiving culturally sensitive care and a lot of support for making shared decisions, and in other circumstances a lot of racist behavior and paternalism.
Great, thank you. So we have another question coming in from the West. They say, thank you, Sarah, wonderful. Looking into the future where patients are engaged using patient-facing EHRs, how do you see implementation of decision aids and SDM being impacted?
Oh, I'm so optimistic for this. We have in the Greater Vancouver area the clinical systems transformation where you'll have patient-facing EHRs integrated across multiple hospital sites. So I'm hopeful that at some point we can have decision support tools or patient decision aids incorporated into those EHRs. And I've seen some really exciting work out of California from some different research teams where they have been doing that. Again, I'd like to see what the difference is in the shared decision-making interactions that take place that are conducted where the patient is doing an activity on their own time versus a decision-making process that's supported by a decision aid in the clinical encounter. I'm not sure. I don't know if we have enough evidence yet to say that one would be superior to the other, but I do think that anything that integrates the patient and provider's tools together, where they speak to each other, is going to be better than if a patient or provider are doing an activity alone.
Great, thank you. Another question also from the West. They asked, will this type of research be extended to women who will experience their first birth?
Yeah, so the component that we're hoping to have integrated is a little bit about the mental health and well-being piece. So there's another bit of work and quality improvement taking place to support women to think about their mental well-being in their first pregnancy so that they have information and resources and can make more informed choices in the postpartum period. So for instance, we often see that women have unrealistic expectations about their potential outcomes in labor and delivery, and it's their first birth. And so we want to have that debriefing exercise that's after a traumatic emergency C-section to be something that can be adapted to train healthcare providers to provide some information prenatally about mental wellness and then some supports postpartum for anybody who's just had a childbirth to debrief their experience and make sure that the woman has good information before she leaves the healthcare system.
Excellent. Okay, we've got another question from France's team. They asked, do you think that clinicians' preferences could play a key role in the women's decision-making process?
The data certainly suggests that, and it's in some cases we found that it was explicit, where healthcare providers reflected and acknowledged that they know that they have a lot of power over women's preferences and decision making, and a few words shared in the postpartum period can really plant a seed for women in framing what her options are moving forward. I think that kind of reflexive activity is something that we could design as part of a shared decision-making training intervention to highlight how words are powerful and being careful in that postpartum period around what you say are the options for next mode of delivery, and also what you say about that first birth experience. So yeah, I mean, that was really a large part of the paper we produced called Do Women Have a Choice that we published in the journal Birth.
All right, thank you. I think we have time for one more. So we have another one that says, hi, Dr. Munro, thanks for a wonderful presentation. Do you anticipate that the findings related to timing of shared decision-making tools, i.e. prior to consult with clinician, can be extrapolated to fields beyond women's health?
Yes, and one thing that I'm really interested in is the idea of timing not being really a one-off thing, so that you're doing an intervention just at one time, but seeing the timing of shared decision-making as an iterative, cyclical, recurrent process. And I think that this has, implications for people who are making multiple decisions over a period of time for chronic diseases or changing medication plans, that we need to think about how to support people as their clinical situation changes and a new decision needs to come up. So how do we support people who are living with making multiple decisions for their patient experience over a period of time? And that's across lots of different clinical areas, I'm sure, outside of maternity.
All right. Well, that takes us right to our time. So thank you so much, Dr. Munro, for your presentation. That was a great presentation and great Q&A. Thank you, everyone, for attending. Thank you to Dr. Lee for moderating. I would really appreciate it if everyone could fill out an evaluation. I have electronic copies. There's also an online version in Qualtrics that you should have a link to. And finally, our next session will be on October 11th with Dr. Martha McLeod on the topic of honoring practice, dialogue, and difference, taking a hermeneutic approach to knowledge translation. So thank you again, Dr. Munro, and everyone for participating.
Thank you very much for the opportunity.
Thank you. Bye, everyone.